In this lecture, we will be discussing those elements that I consider to be the foundational principles in the analysis of sonograms taken on patients suspected of harboring an ectopic pregnancy. In other words, this is the information that I believe we need to know to safely and properly interpret such cases. It is my fondest hope that when I finish this lecture, you will say to yourself, I knew everything he said during that lecture and frankly could have given it much better. During this lecture, I would like to introduce you to what I call the concept of risk stratification. Employing this concept will enable you to have a relatively exact idea of where your patient resides in the pool of women at risk for ectopic pregnancy from when they walk through the door, hand their requisition to the receptionist, to when they walk out the door to see their physician. To begin this journey, we need to know the general population risk for ectopic pregnancy in the United States. Although there is not one number universally accepted by all researchers, 1.5% is a good estimate. So if you are pregnant in the United States, you have approximately a 1.5% chance that the pregnancy is in an ectopic location. While there is dispute about exact numbers, everyone agrees that this is a significant maternal risk factor in the United States. When I was in medical school in the late 1960s, the population risk was only 0.5%. Thus, ectopic pregnancy has tripled in incidence in the United States in less than a half century. Ectopic pregnancy is a disease that goes hand in glove with infertility. A randomized French study showed that after 2 years, the rate of spontaneous intrauterine pregnancy was less than 70% in women who had been treated for an ectopic pregnancy. Method of treatment did not alter the statistic. Although the lethality rate for ectopic pregnancy has fallen dramatically, it remains the number one cause of death in the first trimester of pregnancy. I have been an expert witness in 6 cases where the woman died from her ectopic pregnancy. I am sad to have to report that in every instance, the death could have been avoided with appropriate interpretation of the patient's sonogram. During the course of this 2-lecture series, I will share some of these cases with you. And lastly, ectopic pregnancy is the leading cause of malpractice litigation in ultrasound after obstetrical sonography. Prior ectopic pregnancy is a risk factor for occurrence. The estimates vary from 8 to 20% for a recurrence of ectopic pregnancy, but a 10 to 12% risk is likely near to reality. This is, of course, many times higher than the general population risk. Damage to the fallopian tubes is the leading cause of ectopic pregnancy. In the era when salpingectomy was the method of choice in the treatment of ectopic pregnancy, 75% of excised tubes showed evidence of chronic inflammation. An area that remains controversial in terms of the etiology as to why it happens is the IUD. However, it is not controversial that this is a significant risk factor. Women who conceive with an IUD in place are approximately 7 times more likely to have an ectopic pregnancy than women who conceive without an IUD in place. Here we see such a case with a well-positioned IUD in the endometrial cavity and an ectopic pregnancy in the right adnexa. On this side of the slide of the chart, we see instances where doctors have been fooling around with Mother Nature. These women are all at significant risk to harbor an ectopic pregnancy. Indeed, women who have had a laparoscopic tubocoagulation to induce permanent sterility, if they get pregnant, they have greater than a 50-50 chance of having an ectopic pregnancy. The left side of this list is important to us because these are women who are the source of asymptomatic patients who show up in your lab with a requisition that says, rule out ectopic pregnancy. Having said all of that, there is only one risk factor that we must all keep constantly in mind. Any woman of childbearing age is at risk to harbor an ectopic pregnancy. Therefore, rule number 1, establish pregnancy location in any woman with a positive HCG titer or recommend continued observation. I'd like to tell you that the most important thing that has happened in the world of ectopic pregnancy diagnosis was the advent of sonography, since I had a significant hand in that. However, it wouldn't be true. Ectopic pregnancies produce less HCG than normally implanted pregnancies. We will return to this notion during the second lecture. In the era when I started evaluating patients suspected of having an ectopic pregnancy with sonography, the pregnancy test that was widely used was the hemagglutination inhibition test. However, that test could only detect 2,000 milli-international units of HCG per ml. That meant that half of the women with an ectopic pregnancy had a negative pregnancy test. This group was fundamentally impossible to deal with. Then along came the radioimmune assay for HCG, which increased the sensitivity for this test 1,000-fold overnight. We can now state with near complete certainty that a woman with an HCG level of less than 5 milli-IU is not pregnant, not in her uterus, and not in an ectopic location. The principal value of sonography in patients suspected of harboring an ectopic pregnancy is summed up in this slide. In all published sonographic series, the identification of an intrauterine pregnancy effectively removed the patient from the group at risk. I am fully aware that nearly everyone listening to this lecture has heard about or even seen a heterotopic pregnancy, a circumstance where there is both an intrauterine pregnancy and an ectopic pregnancy simultaneously. We will deal with the heterotopic pregnancy in the second lecture. It doesn't matter to me whether we identify the pregnancy on a transabdominal sonogram or an endovaginal sonogram. However, calling something an intrauterine pregnancy is a diagnosis like any other diagnosis. Listed here are those findings that I consider sufficiently reliable that one can make a firm diagnosis of an IUP. These include the double sac sign, the identification of a yolk sac, and the identification of an embryo either with or without a heartbeat. Unfortunately, certainty increases in this direction, but our ability to see the finding at an earlier stage in gestation increases in the opposite direction. Illustrated here are the earliest definitive diagnostic signs of a pregnancy. The double sac sign, an inner ring surrounded by an outer ring of bright echoes, and the yolk sac. However, we have yet another important diagnostic task. That is to confirm that the pregnancy we are looking at is intrauterine. This means that in addition to adhering to strict morphologic criteria for the diagnosis of the pregnancy, we must also confirm that the pregnancy is surrounded 360 degrees by myometrium in orthogonal planes. Here we identify the earliest signs definitive for an intrauterine pregnancy, the double sac sign and the yolk sac. Now, because modern instrumentation enables us to see the yolk sac at a much earlier stage of pregnancy than previously, that has diminished our reliability on the double sac sign. Nonetheless, the double sac sign is still useful to us because in addition to being able to see the yolk sac at an earlier stage of gestation, we are also able to see the gestational sac at an earlier stage of gestation. Here we can see the double sac sign, an inner ring of bright echoes and an outer ring of bright echoes in a very early intrauterine pregnancy. Additionally, this image shows us the true origin of the bright rings of the double sac sign. They constitute the inner ring, which are the developing chorionic villi surrounding the developing gestation, and the deepest layer of the decidua. Here is the endometrial cavity, the more superficial decidua, and the deep decidua. So if we wanted to give a highly specific name to the double sac sign, it would be called the chorion deep decidual sac sign. When I originally named the double sac sign, I called it the double decidual sac sign, which we now know was clearly a misnomer. I thought that this sign came from the decidua capsularis abutting the decidua vera. We are now aware that the inner rim are the developing chorionic villi, and the outer rim is the deepest layer of the decidualized endometrium. So rule number 2 is confirm the gestation to be intrauterine. That means it is surrounded 360 degrees by myometrium in orthogonal planes. Now, that's myometrium, not just any tissue. So job 1 is always to confirm we are looking at the uterus, we have identified the myometrium, and that the gestation we are about to diagnose is in fact surrounded by myometrium. This is a surprisingly common problem detected in malpractice cases. So, forewarned is forearmed. My next admonition is to beware of the pseudogestation sac of ectopic pregnancy. Under the influence of pregnancy hormone, the endometrium decidualizes. Here you see an image of an expelled decidual cast in a patient who has an ectopic pregnancy. Indeed, a small percentage of patients with ectopic pregnancies present because they expelled a portion of their decidual cast and believe they have spontaneously aborted their pregnancy. When I first began to write about changes in the endometrium that could fool us into believing we were looking at a pregnancy, I erroneously called these changes decidual casts. While decidual casts were the origin of the problem, they were not the problems themselves. As you can see, decidualized endometrium simply looks at nice, thick, succulent, secretory endometrium. This appearance is not what fools us into thinking we are looking at an early pregnancy. The endometrium of patients with ectopic pregnancy can have a variety of appearances. It can be thin, it can be thick, and it can be necrotic, but these are not structures that look like intrauterine pregnancies. Before the advent of modern high-resolution equipment, liquid blood or blood clots in the endometrial cavity could resemble an IUP. From my perspective, that is now far less likely than in previous years. Nonetheless, it is still a reason why sonologists misdiagnose an intrauterine pregnancy. However, they do not mistake the blood clot or liquid blood for a normal intrauterine pregnancy, but instead for an abnormal intrauterine pregnancy. This mistake is equally problematic because the operative words are intrauterine pregnancy, not normal versus abnormal intrauterine pregnancy. The appropriate term for our nemesis is the pseudogestation sac of ectopic pregnancy, not decidual cast. This is a troublesome variety of decidualized endometrium that simulates an early gestation. With modern equipment, it is uncommonly seen today. Previously, you can appreciate that these were more problematic. Here are two patients. Both have similar-sized endometrial fluid collections. Both are pregnant. However, in the patient on the left, the fluid collection is surrounded by a single rim of bright echoes. In the patient on the right, the fluid collection is surrounded by two discrete rims of bright echoes, the double sac sign. Therefore, we can identify this as an intrauterine pregnancy. We cannot identify this as an intrauterine pregnancy, and well, we should not, because this patient had an ectopic pregnancy. As I previously stated, it is currently unlikely that one mistakes a pseudogestation sac as a normal pregnancy. It is much more often mistaken for an abnormal intrauterine pregnancy. As I noted earlier, this mistake is equally problematic because the operative words are intrauterine pregnancy, not normal versus abnormal. The example on this slide was misdiagnosed as an abnormal intrauterine pregnancy, leading to a malpractice litigation. Again, we must be rigid in the criteria we apply to the diagnosis of intrauterine pregnancy. The least reliable we will use is the double sac sign. The collection on the left does not demonstrate a double sac sign. It does not demonstrate a yolk sac. It does not demonstrate an embryo with either a heartbeat or without a heartbeat. The image on the right demonstrates a double sac sign. Here we see a pseudogestation sac in a patient where there is a mild technical challenge to endometrial visualization. We do not want to mistake this as an abnormal intrauterine pregnancy. As discussed, the double sac sign is the least reliable sign we will use to diagnose an intrauterine pregnancy. I first described the double sac sign in 1982, and it never once led me astray. However, when I am going to use the double sac sign, as the one and only criterion to diagnose an intrauterine pregnancy, I choose the image that I will demonstrate to the jury. Visualization. So, rule number 3. Visualization of an intraendometrial fluid collection surrounded by an echogenic rim is an insufficient morphologic criterion to diagnose an intrauterine pregnancy. Rule number 3. Visualization of an intraendometrial fluid collection surrounded by an echogenic rim is an insufficient morphologic criterion to diagnose an intrauterine pregnancy. A finding you may have read about is the so-called intradecidual sign. And you may wonder why I did not include this sign as definitive. I will address this momentarily, and we will also discuss this in the second lecture. This sign was described many years ago when blood products in the endometrial cavity commonly masqueraded as an intrauterine pregnancy. Dr. Ye, the person who described this finding, stated in his paper that blood products were in the endometrial cavity, but true pregnancies were not. The pregnancy actually invades the endometrium, thus it resides within the tissue of the endometrium, i.e., it is intradecidual. One can see that the endometrial cavity reflection actually bumps over the gestational sac. As an aside, the placenta always develops where the endometrium was invaded by the blastocyst. Thus, one can predict that this pregnancy will have a posterior placenta. The intradecidual sign is more convincing as a sign of an intrauterine pregnancy when one adds the observation that the tissue surrounding the sac is thick and more echogenic than the surrounding decidua. It isn't a true double sac sign, but it is one more piece of useful information. My personal report would state that, while not definitive, there is a very high probability that this structure is an intrauterine pregnancy. The reason I do not include the intradecidual sign as a definitive sign for an intrauterine pregnancy is an entity called the, quote, decidual cyst. In their original paper describing the decidual cyst, Levy and Lyons entitled the paper, quote, the decidual cyst, endovaginal sonographic sign of ectopic pregnancy, end quote. Thus, they believed that the identification of a decidual cyst indicated the presence of an ectopic pregnancy. They noted decidual cysts in 14% of ectopic pregnancy patients. Frankly, I can no longer remember which one of these two patients had a decidual cyst and which one had an intrauterine pregnancy. Importantly, however, no normal intrauterine pregnancies are far more common than are decidual cysts. If one looks, it is not at all infrequent to see a decidual cyst in a patient with an unambiguous intrauterine pregnancy. When no easily identifiable intrauterine pregnancy is present, one carefully scans the entirety of the endometrium multiple times to ensure that no sac-like structure is visible. However, once an IUP is easily demonstrated, there is no reason to continue the search of the endometrium. a search that might disclose a decidual cyst. If you look around in patients in whom you've already identified an IUP by definitive criteria, I assure you that you will find a reasonable number of decidual cysts in association with pregnancy. Pregnancy, decidual cyst, and another decidual cyst, pregnancy and a decidual cyst. This patient indeed had an IUP that ultimately produced a singleton fetus. There are 4 sac-like structures in the endometrium. You can try to sort out which is the pregnancy and which are decidual cysts. Frankly, I gave up. Actually, I didn't give up. It's not in my nature. I would pick the sac in the posterior endometrium as the likely IUP. But I hope you can appreciate that this is not a trivial issue. For these reasons, I continue to maintain that the double sac is the least reliable sign we may use to definitively diagnose an intrauterine pregnancy. However, with modern equipment, we use the double sac sign less frequently. In the transabdominal era, I employed the double sac sign 38% of the time to identify pregnancy. In the endovaginal era, I use it less than 10% of the time. This is predominantly due to the fact that we can much more frequently see a yolk sac in very early pregnancies and can use that feature to confirm that we are seeing an IUP. So rule number 4, to diagnose an intrauterine pregnancy, strict morphologic criteria must be applied. Although the double sac sign is the least reliable morphologic sign, it is highly reliable. I will reiterate that although I refer to the double sac sign with the appellation least reliable, I have never in my 32-year history of using the finding been led astray. Therefore, the double sac sign remains an important morphologic criterion, but is used less frequently with modern equipment. Very importantly, although we exercise considerable caution before declaring that any sac-like structure is an intrauterine pregnancy, it is clearly evident in recent research at Harvard that any rounded sac-like structure in the endometrium is far more likely to be an IUP than a pseudosac or decidual cyst. Therefore, under the circumstances of seeing a rounded sac-like structure, more evaluation is necessary. In our second lecture on ectopic pregnancy, I will go into some of the details of the recent consensus conference statements regarding ectopic pregnancy diagnosis and treatment. But for the moment, understand that the identification of a sac-like structure in the endometrium is a contraindication to intervention for possible ectopic pregnancy. That is to say, that these structures, while not definitive as intrauterine pregnancies for reasons I have just discussed, are likely to be intrauterine pregnancies. Further analysis and not treatment is what is warranted. Finally, I will state that pseudogestation sacs can fool even highly experienced diagnosticians. Dr. Peter Callan, the author of the book on obstetrics and gynecology sonography, bet me $1 that this structure was an intrauterine pregnancy, but that the embryo had no heartbeat. I bet that it was a pseudogestation sac of ectopic pregnancy. In the second lecture, I will explain how I won the bet. The population of concern for harboring an ectopic pregnancy is summarized in this statement. Someone suspects that the patient has an ectopic pregnancy, and the patient has a positive pregnancy test. Frankly, I do not care whether the clinician suspicious of the ectopic pregnancy is a nurse practitioner or the chief of gynecology at the University of California, San Francisco. When I have tested this population, which I have done in multiple research projects, the prevalence of ectopic pregnancy in this group at the University of California, San Francisco ranges from 10 to 20%. For ease of computation, let's take the average and say 15%. This again is our concept of risk stratification. The general population risk is approximately 1.5%. The prevalence in a group of women suspected of harboring an ectopic pregnancy is approximately 15%. Thus, the suspicion of ectopic pregnancy increases a woman's risk tenfold. Nonetheless, the majority of women suspected of having an ectopic pregnancy do not have one. There is nearly universal consensus that sonography is the examination of choice in such patients. If we do that sonogram and we identify an intrauterine pregnancy by the criteria we have described and surrounded by myometrium 360 degrees in orthogonal planes, for all intents and purposes, we have taken that patient out of the group at risk for ectopic pregnancy. So, when we identify these definitive features of a pregnancy and confirm that they are surrounded 360 degrees by myometrium, this patient's risk for ectopic pregnancy becomes essentially zero. The initial sonogram of these patients suspected of having an ectopic pregnancy demonstrates a definitive IUP approximately 72% of the time. So, if the initial sonogram documents an IUP 72% of the time, and the initial sonogram also documents sufficient evidence to state that the patient has an ectopic pregnancy, very conservatively speaking, 2/3 of the time, so there will be 15% of 100 patients who will have ectopic pregnancies. We will document that 10% of those 15% are indeed highly suspicious for an ectopic pregnancy. That means that the initial sonogram categorizes the patient into either the no ectopic group or the ectopic group 82% of the time. So within a half hour of instituting the sonogram, 82% of the time, we have an excellent idea of where this patient is in the world of women who are suspected of harboring an ectopic pregnancy. That is the reason why the phone rings at 3 o'clock in the morning and you are requested to interpret a sonogram of a patient at risk for ectopic pregnancy. Now, in order for the initial sonogram to document an intrauterine pregnancy 72% of the time, that means we must find definitive criteria in at least 85% of the patients who have intrauterine pregnancies. If we now do our sonogram and we search the endometrial cavity and cannot identify an intrauterine pregnancy, that patient's risk jumps from 15% to 55%. How does that happen? Well, we've documented there are 85 IUPs in a group of 100 women who are suspected of having an ectopic pregnancy. And we are unable to demonstrate definitive criteria in 15% of those. That's 14 IUPs. And among 100 women who come with a suspicion of ectopic pregnancy, there will be 15 extrauterine pregnancies. So at this point in time, there are more ectopic pregnancies than there are IUPs. You can adjust these numbers for your lab if you know the detection rates for intrauterine pregnancies and the prevalence of extrauterine pregnancies in patients referred to rule out ectopic pregnancy. Things which increase the prevalence would be, for example, your emergency room physicians do sonograms on all patients where they're worried about an ectopic. They do not send you the cases where they're certain that the patient has an intrauterine pregnancy, only the cases where they are uncertain as to whether the patient has an ectopic or an intrauterine pregnancy. Therefore, it is a pre-screened population. Therefore, the prevalence of ectopic pregnancy in that group will go up. As the prevalence goes up, the inability to identify an intrauterine pregnancy will significantly increase, greater than 55%. Now, in a standard population, no IUP demonstrated, the risk is 55%. So here we have a patient where we can see the endometrial cavity well, we search it, there is no visible intrauterine pregnancy, risk now 55%. What is it that most women have when they are suspected of having an extrauterine pregnancy? Well, as we said, most of them have an intrauterine pregnancy, and most of those will have a normal intrauterine pregnancy. Second is the abnormal intrauterine pregnancy. Here are two examples of cases that you might encounter. Here we run into a problem because in this case and in this case, we do not see a double sac sign. We do not see a yolk sac. We do not see an embryo with or without a heartbeat. So what we cannot say is that these are definitively intrauterine pregnancies. What we can say is that if they are intrauterine pregnancies, they are abnormal. While I typically do not recommend that patients with failed early intrauterine pregnancies undergo uterine evacuation, I think the women are better advised to allow the pregnancy to evacuate naturally under the circumstance where an ectopic pregnancy is suspected. Dilatation and extraction is appropriate so that the products can be analyzed for chorionic villi. If chorionic villi are identified, that was an intrauterine pregnancy, and the patient is out of the group at risk. If no chorionic villi are identified, the patient returns to the group at risk. It isn't until we come to the third position that extrauterine pregnancy shows up. And then lastly, we have spontaneous abortion. Let's now switch our focus from excluding an ectopic pregnancy by documenting an intrauterine pregnancy to actually diagnosing ectopic pregnancy. And here, the good news is there are really only two findings: free fluid and an adnexal mass. Now, that adnexal mass can have a variety of appearances, and those appearances do have significance in how we will ultimately interpret the case. So, remember, we have searched for an intrauterine pregnancy. We could not find it. The patient's risk jumped up to 55%. Now, in addition to that, we identify pelvic fluid. The patient's risk jumps up to approximately 75%. Again, even though this is a transabdominal sonogram, we see no IUP and fluid in the cul-de-sac. This patient's risk level is now stratified in the range of 75%. And I can assure you, when we get to this range of risk, the gynecologist will take the methotrexate off the shelf and will potentially get out their laparoscope. Importantly, we all realize that if we search diligently, we can find some pelvic fluid in virtually any woman. Therefore, it is certain that there are amounts of fluid which are simply too small to call. For myself, I generally will not call a pocket that is less than 1 by 2 centimeters. I especially am interested in trying to identify whether there is clot within that fluid. Which brings me to our next point, and that is, not all fluid is equal. Echogenic fluid is much more suspicious than echo-free fluid. So here we see fluid which is not quantitatively large, but it is echogenic, and we can see fibrin and clot within it. Here again, the volume of peritoneal fluid is not great, but it is echogenic, and this is therefore more suspicious than echo-free fluid. If indeed we are looking at a population of patients who actually have ectopic pregnancies, we can see that fluid is a common finding. More than 2/3 in the Cacciatore series, 75% in the Fleischer series. Now again, we're scanning the patient. We were unable to demonstrate an IUP, therefore her risk jumped to 55%. Now, in addition to that, we identify a mass. Again, the patient's risk of an ectopic pregnancy jumps up to approximately 75%. This is a point at which the gynecologist will consider instituting treatment. The most common mass seen in a patient with an ectopic pregnancy is simply a heterogeneous echogenic mass. Here we have a transabdominal sonogram, an empty uterus, and a heterogeneous echogenic mass in the right adnexa. These masses are almost exclusively, although not exclusively, hematosalpinges. On the endovaginal sonogram in this patient, you can see some of the blood products are bright, some are less bright. In this patient, within the hematosalpinx, we can see that the blood is becoming more hypoechoic. These changes in the echogenicity of blood are typically related to this phase at which you are observing the blood after the bleeding event. Bright blood is usually reasonably fresh. Mid-gray is relatively fresh. Hypoechoic is older blood. So this woman gutted it out for a couple days before she came into the emergency room with her ectopic pregnancy. Masses are common in patients who actually have ectopic pregnancies. More than 60% in Cacciatore series, 2/3 in Fleischer series. Just as not all fluid is equal, not all masses are equal. And a mass that is separate from the ovary is much more suspicious than a mass in the ovary. I will bring up the issue of ovarian ectopics in the second lecture, but it's extraordinarily unlikely that I would ever call a mass within the ovary as a potential ectopic pregnancy. Here we can see one of these heterogeneous echogenic masses, and we can see that it is not actually part of the ovary. It lies adjacent to the ovary. One of the things that we can do to show that a mass is separate from the ovary is to employ compression. This works in a very high percentage of cases, and I use it very extensively. So this mass clearly moves in a different way than the ovary moves as compression is applied with the transducer. So echogenic fluid and an echogenic mass. As I said, we will deal with the ovarian ectopic pregnancy in the second lecture. So here we see a mass that appears to be within the ovary as it moves with the ovary. Here we see a mass that moves separate from the ovary. And of some considerable interest, I would like you to see that compression actually is helping us to see the mass. When compression is relaxed, you will notice that the mass is reasonably inconspicuous. The mass becomes increasingly conspicuous as pressure is applied. So compression has a variety of useful adjuncts. Helps to separate masses in the ovary from masses separate from the ovary. Helps us to see inconspicuous masses from time to time. And also, the patient will frequently complain, ouch, that's exactly where it hurts, doctor. So, again, we are interested in finding masses that are separate from the ovary. We'll now take up a structure that I described many, many years ago, the adnexal ring. So no one would be happier than me if the adnexal ring was the end-all and be-all of the diagnosis of ectopic pregnancy. It still has some good points, but it also has some bad points, and I think you need to have a good understanding of the difference between the good points and the bad points. So, certainly it is true. Here's a patient with an ectopic pregnancy, and this ring-like structure is reminiscent of a pregnancy, and it is outside of the endometrial cavity. Notice that this patient has a decidual cyst. By contrast, here we have a patient with no IUP and free fluid. We see this adnexal ring, but this adnexal ring is within her ovary, and this is a corpus luteum. Now, clearly, every woman with a pregnancy will have a corpus luteum. The corpus luteum is frequently ring-like, and that means that the advantage of identifying an adnexal ring is greatly blunted by that fact. Having said that, a woman typically has a single corpus luteum, so when you see two adnexal rings, then one should be suspicious that only one of them is a corpus luteum. Furthermore, you can see by the follicles that this adnexal ring is in the patient's ovary, whereas this adnexal ring is adjacent to the patient's ovary, therefore extremely suspicious for an ectopic pregnancy. Now, I used to say that the ectopic and corpus luteum adnexal rings looked virtually identical to each other. That turns out not to be true. Recent observations by Dr. Freitz at Harvard have taught us that the adnexal ring of the corpus luteum typically has echogenicity very similar in amplitude to the stroma of the ovary, whereas the adnexal ring of the ectopic pregnancy, surrounded by chorionic villi, is very much brighter than the echogenicity of the stroma of the ovary. So in this case, we can see that this adnexal ring is more echogenic than the stroma, whereas this adnexal ring is identical to the stroma. Also, we can appreciate that this adnexal ring is extra-ovarian. All of these things help us. It helps us with the visibility of the adnexal ring that is caused by the ectopic pregnancy, and helps us to discriminate adnexal rings from a corpus luteum from an adnexal ring caused by the ectopic. Another advantage of the adnexal ring is here we see a patient with an empty uterus and a heterogeneous echogenic mass in the left adnexa. Now her risk is 75%, but when we examine the mass endovaginally, even though it's not absolutely typical echogenic ring, there is definitely a ring-like structure within the hematosalpinx, which to me increases the probability significantly that the patient actually has an ectopic pregnancy. Therefore, I would upgrade the level of risk. I would stratify her risk to a higher level than 75%. Here we see a patient with two adnexal rings. Could she have twin ectopics? Indeed, twin ectopics exist. Even triplet ectopics have been reported. So, when we examine the patient endovaginally, we can see that this is a corpus luteum, and this is a lesion that has a brighter rim and also has a little yolk sac within it. So here is our ectopic pregnancy. Now, I want to make a statement that anytime you find a mass wedged between the ovary and the uterus, a mass wedged between the ovary and the uterus, it is almost invariably an ectopic pregnancy. So here on a transabdominal sonogram, we see the uterus well. We can see the endometrial cavity. We do not see an IUP. We look into the adnexa. We see an adnexal ring. We realize that the adnexal ring is not the end-all and be-all of the diagnosis of ectopic pregnancy, but it does give us a focus for our endovaginal exam. We want to take a close look at the adnexal ring with our EV transducer. And when we do, without question, we see a little yolk sac and a little embryo. So now we have definitively identified an extrauterine pregnancy. So as we have just suggested, if we actually identify an adnexal embryo, then the probability that the patient has an ectopic pregnancy is now 100%. Sensitivities for identifying adnexal embryos in the literature range from about 15 to 35%. Now I know you're saying to yourself, I don't detect anything near that number of adnexal embryos, but you probably are doing that. You probably are actually successful at doing that. Remember, on average, you're going to see this in about 25%, so 1 in 4 ectopics. So that's 1 out of 4 of the 15 ectopics, or somewhere between 3 and 4 per 100 cases where the patient comes with a requisition that says rule out ectopic pregnancy. So the 3 or 4 per 100 times that you see an adnexal embryo when you have a requisition in your hand that says rule out ectopic pregnancy gives you the false impression that you don't detect adnexal embryos as well as has been stated in the literature. It's likely that you actually do. So here we have a patient where we identify an adnexal embryo. We can see with color Doppler that it has a heartbeat. There is no question but that the patient has an ectopic pregnancy. Here is the patient. Here's another patient where we can identify a yolk sac. An ectopic yolk sac is as good as an ectopic embryo with a heartbeat. There's a yolk sac. There's a yolk sac. Any embryonic structure that you can identify is proof positive that the patient has an ectopic pregnancy. So, we have identified all of these potential abnormalities that we might see in the patient's adnexa. But what if we find nothing in the adnexa? What if it's perfectly normal? Does that take the patient out of the group at risk for ectopic pregnancy? And the answer to that question is a definitive no. In the literature, anywhere from 7 to 33% of patients who have no adnexal findings have an ectopic pregnancy. So here we have a patient with no IUP, a perfectly normal left ovary with no mass and no fluid identified. She, in fact, has an ectopic. So rule number 5 is the absence of adnexal findings does not exclude an ectopic pregnancy. Patients with an absence of adnexal findings and an ectopic pregnancy are all unruptured. When you are describing such a case, even though the patient has a normal sonogram, do not describe it as a normal sonogram. Proper descriptive phrases will be discussed in the subsequent lecture. So, when we are scanning a patient, we see no intrauterine pregnancy. We look into her adnexa. We can increase her risk anywhere from 75% up to 100%, depending on the finding or combination of findings that we identify. But importantly, at no time can we take the patient out of the group at risk. Let's have the difference and say it's about 15%. So the patient walks in the door. She has a risk of 15%, 10 times the risk of a woman who is simply pregnant in the United States. If we can identify an intrauterine pregnancy, we take her out of the group at risk for an ectopic. If we cannot identify an intrauterine pregnancy, her risk level jumps to 55. From that point, we can increase her risk anywhere from 75 to 100%, depending on the findings or combination of findings that we identify. However, we cannot take the patient out of the group at risk. As I said, think 15%. Therefore, the patient walks out the door with the same risk that they walked in the door. So, stratify your patient's risk and obey the 5 rules. Both you and your patient will stay out of trouble.